Hey, welcome back to Not So Complicated, and today we'll be talking about amyloidosis, its types, pathophysiology, diagnosis, and management, right? So let's begin without further delay. These are actually a rare group of disorders where misfolded proteins form insoluble amyloid structures, right? Fibrils, and these deposit in different organs causing dysfunction. They can deposit in eyes, like manifesting as raccoon eyes, and thyroid gland is hypothyroidism, then heart is heart failure or congestive heart failure, right? So splenomegaly, hepatomegaly, and in kidneys it can manifest as nephrotic syndrome. In joints it can manifest as chronic synovitis or tunnel syndrome, right? So it also appears the changes in skin. So this is actually what amyloidosis is. There are different types of amyloidosis. Let's talk about that, right? The first one here is AL type actually. So L is light chain type. So light chain amyloidosis is the first type. The other type is ATT type, that is transthyretin type, and then it has two types in it itself, right? So the first one is hereditary, it can be due to genetic mutation kind of thing, and the other is wild type, that is age related. So these are two different ATT types, and the final type is A type, that is amyloid A, and it is secondary to chronic inflammation like rheumatoid arthritis actually, right? So these are the types of amyloidosis. Talking about pathophysiology, what actually happens is that proteins like light chains or transthyretin, they misfold into beta-cet structures, right? These beta-cet structures, misfolded beta-cet structures, form insoluble fibrils that deposit extracellularly in tissues, right? And the fibrils mechanically disrupt organs like stiffening the heart in cardiomyopathy or triggering inflammation or oxidative stress causing toxicity. So this is like causing toxicity due to apoptosis also, right? So this is how disease like clinical manifestations are appearing out of amyloidosis. There is type specific pathophysiology also. Let's talk about that. In AL type, that is light chain type, so plasma cells overproduce light chains actually, right? So in plasma cell dyscrasias, light chains like kappa or lambda light chains, they are overproduced and they get deposited in heart, kidneys, and gastrointestinal tract. And in ATTR, that is mutated or unstable transthyretin forms fibrils, right? Right. So in hereditary type, so there is TTR gene mutation, example BAL30 MET mutation, and that will lead to neuropathy or cardiomyopathy. And in wild type WT ATTR, there is ARIDS related TTR instability causing cardiomyopathy, right? So the last one is AA, that involves serum amyloid A from chronic inflammation like rheumatoid arthritis. I had talked about it earlier. So it is related with SAA protein, and deposition occurs in kidneys and liver causing nephrotic syndrome or renal like enlargement or hepatomegaly or liver failure, right? So these are the type specific pathophysiology. So talking about clinical features of amyloidosis, so there are different organ specific clinical features, right? So in cardiac regions like cardiac system, there is AL or ATTR type working, causing restrictive cardiomyopathy, and that will lead to heart failure, that is dyspnea, that is obviously difficulty in breathing, edema, and arrhythmias, low ECG voltage, and increase in brain natriuretic peptide because there is excessive stretching of the heart muscle, right? And in renal manifestation, that happens in AL and AA type, nephrotic syndrome is appears, and then nephrotic syndrome is obviously greater than 3 gram per day of release of protein, causing edema, hypoalbuminemia, and also hyperlipidemia actually, right? So the another one is neurologic features that happens in HATTR, that is hereditary transthyretin mutation causing peripheral neuropathy, and that will lead to sensory loss, autonomic, that is orthostasis, or GI dysmotility, right? So the other lesions or other manifestations are in AL, you can see macroglossia, that is enlargement of tongue, periorbital purpura, easy bruising, hepatosplenomegaly obviously, and in ATTR, that is carpal tunnel syndrome, spinal stenosis, and vitreous opacities, right? So these are the clinical symptoms or features that you can see. And in diagnosis of amyloidosis, you have to do the step one is biopsy, that is fat pad or bone marrow or organ, any organ that is deposited, like any organ where amyloid proteins are deposited, you have to take the biopsy of that and do the Congo red stain, and that will show apple green birefringence or under polarized light actually, right? So this is the step one. And step two is protein typing to distinguish which type it is. So mass spectrometry can be done, that is gold standard, or immunohistochemistry can also be done, that is less specific actually. So the lab values are also like noted for the diagnosis. So in AL there is increase in free light chains, bone marrow is greater than 10, bone marrow has greater than 10% of plasma cells, and in ATTR there is TTRs in sequencing. Example, BAL30 MET mutation is a kind of genetic mutation in ATTR, right? So in AA there is increase in SAA protein, underlying inflammatory markers like CRP, that is C-reactive protein, which is acute phase reactant also, and ESR, that is erythrocytic sedimentation rates, right? So talking about management of amyloidosis, AL has chemotherapy, that is like the most common is commonly used chemotherapy medication is Cybord actually. So Cy is cyclophosphamide, and Board is bortezomib, and D is dexamethasone, which is a steroid. And you can also use daratumumab, which is monoclonal antibody, and also can stem cell transplant can be done. And in ATTR you would use stabilizers like tafamidis first, and genetic silencer in different types. Like in ATTR neuropathy you use patisiran, inotersen, or in ATTR-CM you use vutrisiran. This is FDA approved, recently FDA approved drug actually, right? So in AA type you use, like, you treat the underlying lesions in this. So example, anti-TNF, that is tissue necrosis factor for rheumatoid arthritis, or the tocilizumab for infections, right? So this is how you treat specific type specific amyloidosis actually. So this is the summary table. This is the summary table of all specific type specific findings. You can go into that, right, to revise. So talking about median survival out of this, so median survival rate of AL type is 1 to 3 years, AA is 11 years, ATTR M is 2 years, and ATTR WT is 4 to 6 years. You have to remember this, right? So that is all for today. Subscribe for more, and thank you for staying with me. I hope this helped. Please subscribe.